Welcome to the Long-Term Care Mutual Aid Plan Refresher Training. This is presented by the Virginia Healthcare Emergency Management Program. My name is Robert Hawkins. I am the Director of Emergency Preparedness for the Virginia Hospital and Healthcare Association. This training was developed in partnership with each one of our regional healthcare coalitions in the Commonwealth of Virginia to assist with the ongoing support for the Long-Term Care Mutual Aid Plan. The Virginia Department of Health, in partnership with the Virginia Hospital and Healthcare Association, supports hospitals and healthcare facilities with the development of the Virginia Healthcare Emergency Management Program. This is constituted by 4 regional healthcare coalitions who are responsible for the development of preparedness and response activities of our healthcare partners. Our agenda is to review major historical events, the Virginia Long-Term Care Mutual Aid Plan, or LTC map, with an overview, to discuss evacuation planning, incident command systems, and then discuss the next steps following today's session.
I'm Harry Grunsbeck with the Northern Virginia Emergency Response System, and I'll be covering a review of major historical events as we move through the content today. Hurricane Irma, which impacted Florida in 2017, and specifically the rehab center at Hollywood Hills, served as a major catalyzing incident for skilled nursing facility emergency preparedness. The 152-bed facility lost power and air conditioning following the hurricane making landfall, and temperatures soared to over 100 degrees. 12 fatalities were ruled homicides at the time within the facility, and facility license was revoked. Hurricane Ida, which impacted Louisiana and other Gulf states in 2021, impacted 7 facilities that were under a single ownership group. A follow-up investigation by the Louisiana State Department of Health found that the nursing homes failed to execute on an evacuation plan that upheld residents' human dignity. 7 residents died after being placed on mattresses, sitting in stormwater, and left in human waste in an unsuitable warehouse used as an evacuation site. In this case study as well, the facility licenses were revoked.
My name's Megan Doran, and I'm with the Northern Virginia Emergency Response System. I'm going to be speaking to you about the Virginia Long-Term Care Mutual Aid Plan history. So the LTC map, history and background, originated in the Northern Virginia as a special project. Site visits were conducted by a contractor, and generator and facility surge information was collected and placed into the Virginia Healthcare Alerting and Status System, otherwise known as VHHA. Upon state expansion, the MOU was created in coordination and cooperation with a number of different groups, including VHCA, Leading Edge Virginia, DMAS, VDH, VHHA, and was implemented in early 2018. Mutual aid is common among police, fire, and EMS and utilities, and given that these groups are closely tied to geographical boundaries, mutual aid agreements allow for them to quickly scale their resources to meet community needs. Similarly, the Virginia Long-Term Care Mutual Aid Plan allows for skilled nursing facilities to voluntarily aid each other in the event of an emergency. LTC MAP stakeholders, such as Virginia skilled nursing facilities, hospitals, government and private EMS agencies, state, regional, local emergency management, and public health departments, as well as the greater community and resident families, are important stakeholders for the LTC map and reap the benefits from its use. There are a number of scenarios in which the LTC map could be utilized. The first being a single facility isolated incident such as a fire or a utility outage. Another situation in which the LTC map could be called upon is the single facility or local area-wide incident. An example of this would be an area flood event or storm, etc. Greater impacts such as multiple facility or statewide or regional incidents such as derechos, hurricane events, etc. that impact multiple facilities over a large geographical area could also trigger the LTC map. The LTC map delineates groups into one of 2 categories. Disaster-struck facilities, or a facility that's been impacted in an emergency or a disaster, or a resident accepting facility, a facility that is providing resources or an evacuation support to a disaster-struck facility during an emergency or disaster situation. The LTC MAP framework really provides a mechanism for how this support can be provided between both disaster-struck facility and the resident accepting facility. In this way, place and support care of residents from the disaster-struck facility can be maintained. Provision of equipment, supplies, pharmaceuticals as necessary to the disaster-struck facility, as well as assistance with the transportation of evacuated residents. Additionally, provision of support is necessary to the disaster-struck facility or resident accepting facility, whether evacuating, surging, sheltering residents, or sheltering in place as well. By signing the LTC MAP, member facilities voluntarily agree to accept additional residents up to 110% of licensed capacity, activate internal emergency operation plans or EOPs and internal command centers, update the long-term care status board and the event log and or SITREP in the Virginia Healthcare Alerting and Status System or VHHA, update VHHA organization profiles and user accounts annually, and also participate in regional training and exercises. Members also agree to send active medical record charts with each evacuating resident and accept responsibility for providing current critical information via VHHA and updating information annually at a minimum. The graphic on the right-hand side of the slide is available in the LTC MAP Memorandum of Understanding and outlines the LTC MAP emergency activation algorithm, which details processes, communications, and actions for if and when the LTC MAP is activated. These communications include RHCC notifications and activations, VHHA alerts, region-specific communications and redundant communication, as well as media public communications. The LTC MAP also provides a framework for borrower and lending facilities to share resources. Resources may be needed by a disaster-struck facility that is not evacuating but is overtaxed by a disaster and needs additional support, a resident accepting facility that requires additional resources to handle an influx of residents, or a stopover point to which a disaster-struck facility has been evacuated to. As you can see from this slide, there are numerous responsibilities for both disaster-struck facilities as well as resident accepting facilities. Some actions of the disaster-struck facility include following the LTC MAP activation algorithm, notifying resident accepting facilities, as well as managing stopover points. Actions for resident accepting facilities would include monitoring the VHHA event log, managing resident care, as well as activating their command center and assisting with resident placement. In addition to these actions, the LTC MAP also includes several appendices with important information such as the activation algorithm, resident medical records, staff, equipment, tracking sheets, resident emergency evacuation form, nurse, physician decision-making guidelines, as well as influx residence log, controlled substance receiving log, long-term care tracking boards, resource request form, and Joint Commission emergency credentialing standards. In summary, participation in the LTC MAP is voluntary. Planning allows for long-term care facilities to voluntarily assist each other in times of an emergency and reduces impact on community emergency services, reduces impact on hospitals, local fire, rescue, and long-term care facility staff, as well as reducing impact on residents and their families. Disasters will happen, so having a framework for requesting help before a disaster strikes is easier and more efficient than asking for help after an event. The LTC MAP MOU was originally created and signed in 2018 and expired on December 31st of 2022. An extension was created in 2022 to renew the MOU for an additional 5 years. Again, this participation is voluntary, and facilities are the only ones that sign the Memorandum of Understanding. This defines the relationship between facilities for borrowing staff, borrowing supplies and equipment, as well as transferring evacuation of residents and DMAS reimbursement policies. Healthcare coalitions throughout Virginia will continue to promote the LTC map and update MOUs as needed due to name changes or facilities who have not yet signed on. Long-term care map partners will utilize the LTC map for training and real-world events, and regional healthcare coalitions will provide training and education based on lessons learned from cross-regional LTC map exercises conducted in spring 2022. Statewide, there is a phased approach for updating the LTC map to be ready for the facility signatures by December of 2027.
Now we'll talk about evacuation planning, including slow-out evacuations and fast-out evacuations. The LTC map supports using close proximity open beds and having LTC map member facilities search to 110% of their licensed beds as necessary. Note that if the evacuation is a slow-out situation, whereby all parties are aware that the facility will not be reopening in the near term, this can be because of flooding, facility damage, or a similar emergency, then the Regional Healthcare Coordination Center, or RHCC, should be supporting the disaster-struck facility to find open beds within the region and potentially outside the region or state for long-term resident placement if required. Agreements should be updated annually, and any agreements are the facility's responsibility. Fast-out evacuations. Residents may need to be moved to a stopover point or may bypass a stopover point and move directly to a resident accepting facility, utilizing their surge capacity plan to exceed licensed bed capacity to shelter those residents for a short period of time until they can return to the disaster-struck facility or be moved into open beds. So this stopover point is an interim place where the evacuating facility residents can go. Think more in terms of critical, immediate, dangerous to life and health type of emergencies. It could be a fire, it could be an explosion, something that requires moving the residents out immediately, where there may not be time like there is in the slow out emergency to meter their flow over to those resident accepting facilities. In a fast out evacuation, they may need to go directly to a stopover point. A stopover point should be close to your facility, and it should be a suitable location. If you remember back to the original case studies that we looked at in the beginning of this presentation, we talked about unsuitable sheltering locations in Louisiana. We want the facilities that are used here to be suitable for your residents so that they can be safe and that the needed care can continue to be provided. These stopover points can be used for various scenarios that may require temporary or short-term shelter, and the residents should be quickly removed from the building and it's placed there until a suitable destination is identified. And again, suitable destination should be whatever type of bed they're currently in. So if they're currently in a SNF bed, they should be moving to a SNF bed. We should not be downgrading patients just because they're being evacuated. Residents are evacuated from the facility, but if a facility is expected to reopen in a matter of hours, it may make sense to put them on a stopover point instead of fully evacuating them all the way to a resident accepting facility, only to then have to quickly turn them back around. That may result in them spending much more time in transit on the road or under medical stress than they otherwise would if they're only going to a close by stopover point. Again, assuming that that stopover point is suitable and that all necessary care can continue to be provided for them. You should have documented agreements between your facility and any stopover points. That should be a signed agreement. Those agreements should include primary and secondary points of contact with 24/7 contact information for the facility. If your stopover point is a local recreation center, you need to have the contact information to get in there. Doesn't matter the time, the date, if it's closed because it's a holiday, if it's a church, you need to be able to know who to wake up in the middle of the night to get into the building if it's not always open, or if it's a library, whatever it may be. It may not be a facility that is typically open 24/7. So you want to be able to make sure that when you get that agreement for your stopover point, you have the 24/7 contact information, and should be primary and secondary just in case someone's not available. When you have those signed agreements, those can actually be uploaded into VHAS to document it, and also so that you can quickly reference them in an emergency. Those get uploaded and the information can be placed into the evacuation site tab under surge information, and the signed documents themselves can be placed in the emergency operations tab. When you think about evacuation planning in general and specifically for stopover points, continually think of staff, space, and stuff. Your staff that are going to need to be caring for these residents when they're in this unusual area, the space to make sure that it's clinically appropriate, and the stuff to make sure you have what you need, whether that's medications, ancillary supplies, office supplies, communications equipment, anything you need to be able to continue providing care. So regarding staff, the plan should designate staff roles at your stopover site, and that's your facilities emergency operations plan, or if you have a sub plan dedicated just to stopover points. You should always send a staff member to the site to gain access before any residents have been transported or are on the move to that stopover point. The last thing you want is to have buses stacked up or vans, or have your folks there with their residents and you can't get into the building, or you can get into the building but there's no IT available, or there's no lights, or there's no heat, or there's some unforeseen issue. Designate ahead of time who's going to be responsible for site setup. These are roles that are not necessarily the roles that staff do every single day. So think about, in an emergency, who's going to be responsible for certain actions, whether that's clinical actions, site setup actions, communication with residents and their families, communication with outside partners like the RHCC, your local public health and emergency management partners, fire EMS. Just think through who is doing what ahead of time. Communication. How can the RHCC contact you? How are you going to be able to utilize VHAS? Are you going to have laptops that are able to move to a stopover point or with your folks as they're evacuating? Are they able to access it on their phones or other mobile devices? How are families able to contact you? It's very likely that word will travel quickly that there's an evacuation occurring, and you should expect concerned loved ones to be contacting you, seeking information on the status of their family member who's in the facility, asking where they're going, how long they're going to be there, and other such questions. And also think about how staff can remain in contact with one another. If they're not operating in your regular facility, do you then lose any of the primary methods that staff typically use to coordinate? When you think about space, you should be conducting an annual site visit or walkthrough with any stopover point. Facilities change, their layouts change, the uses within the facilities might change, the administration or leadership of a facility may come in and there might be turnover. They might be unaware that they are serving as your stopover point. So you want to document your proposed site layout, include that in your plan as well. Really encourage you to bring some staff that would actually be participating in an evacuation and the use of a stopover point to do these walkthroughs. It serves as a great quick exercise that they can really put themselves in the mindset when they're walking through the space. And you should also identify a command post so that you have a single stationary area within the stopover point that leadership serving as that incident commander, as that leader during the evacuation, whoever is at that stopover point and is in charge, there is a single place that they will be located. Really important so that they're not ending up running all over the facility trying to fix issues. When outside folks come in looking to coordinate, they know there's one single place, that command post, that's where they report to. And regarding stuff, think through the clinical and non-clinical needs. What are your residents going to need so again that you can maintain that appropriate level of care? And on the non-clinical side, what office supplies are you going to need? Can you pack those up in boxes or in rolling duffels maybe in some way that it's easy to move them over to your stopover point should you need to evacuate? Demobilization is important as well. You should work with the stopover point facility to develop a checklist ahead of time. It's a great idea to take pictures both before and after the facility is used so that you can see that original condition before it was used as a stopover point, and then again, you're documenting that it has been returned to its original condition. Definitely do a walkthrough with a facility representative, again, after demobilization. That really hands it back to the owning facility that serves as your stopover point. Again, document, document, document. It's great to have a facility representative sign off that everything has been returned to its proper condition. And again, make any necessary notifications when all residents and staff have vacated the stopover point, because you want to be really clear so that staff know that that stopover point is done, it has been demobilized, all normal operations have either returned to your facility or the residents have moved on to resident accepting facilities, and that's where they are, but that they're not in that interim location anymore. So covering some of the facility responsibilities, notification of the Regional Healthcare Coordination Center. Again, every region, every healthcare coalition region in Virginia has an RHCC. They are available 24/7, 365 to take these calls. Please have in your procedures, again, it's in the algorithm for activation of the LTC map, but also put it in any applicable facility level plan or checklist to notify the RHCC. Very important, again, to have a staff person that goes ahead, to have like an advanced team that goes ahead to the receiving facility or to a stopover point before anyone else. Ensure the provision of appropriate clinical care. Make sure that there's clinical leadership wherever your patients are, your residents are. So if they're at a stopover point, or if they're in transit, or if they are at the resident accepting facility, make sure that there's someone who is responsible for their clinical care at every step of the way. Transport staff, pharmaceutical supplies, and equipment, again, in coordination with the RHCC and possible local emergency management and public health partners. And the facility also must manage the activation, setup, operation, and demobilization of any stopover point. Some planning basics when we're talking about evacuation. Authority and chain of command are really important. Know that during an emergency, it is very hard to maintain the same level of management and org chart that you have day to day. This is a concept in emergency management called span of control. So whereby normally you may supervise as clinical leadership or an administrator, maybe you supervise 15 or 20 people even. During an emergency, the demands and the stress rises exponentially. So trying to really maintain no more than 4 to 7 people reporting to one supervisor during the emergency is ideal. But if you can't maintain that, still make sure that everyone knows what is the chain of command during this emergency and who has the authority to make what decisions. When we talk about authority, that can include the authority to evacuate, to make that decision that an evacuation is going to happen, the authority to activate your stopover point, the authority to request assistance through the LTC map. Outline who in your facility fills these roles, and again, plan for this to happen at 3 o'clock in the morning on a Saturday, on a holiday weekend. So try not to just vest it all in your administrator and your nursing leadership, your clinical leadership, but think through, okay, do we have 2, 3 deep on a bench to fill these critical roles? Think through your internal and external notification and communication. And when you think about notification and comms, again, take into account that they may be impacted by whatever this emergency is. So if something has caused a major regional power outage and you're dead in the water, you don't have any power to your facility, and your generator is not working, let's say, and you've been forced into the evacuation mode, does that also impact your ability to communicate? Likely, right? You may not have internet. You may not have cell phone service, depending on what's going on. So just think through any redundant communications that you have available to you. Think about the equipment and supply needs. Again, we talked about while staff are waiting for transportation to a stopover point, that can include med sleds or other similar devices, stretchers, chairs, temporary beds, lighting, shelters, and wheelchairs. Incredibly important to track your residents. We urge facilities to create an LTC Map Go Kit. Some of the things that can go in this Go Kit include wristbands to identify residents, a Sharpie so that those wristbands can be quickly written upon, pen and paper so that you can make lists, photos, taking a photo of each resident with their wristband before they're loaded on a vehicle, and putting a sign on a vehicle before it goes to its destination. Again, taking a photo of that vehicle, and having photos of residents as they arrive at the stopover point. Again, these events can be chaotic. We hope they're not. And through this planning process, we're trying to limit that chaos. But it is possible that someone makes it through without 100% proper tracking. Try to implement as many possible redundancies and layers there. So even if they didn't get through, they didn't have the wristband, but they got on the bus, you have a picture of them getting on the bus, you have a picture of them getting off the bus, you know where they are. You may need to make resource requests. We recognize that while facilities have a great baseline level of emergency preparedness, there are going to be times where they need to reach out. You need to ask for assistance with resources. To this end, we utilize what's called CSALT. That's CSALTT. That stands for capability, or what do you need a resource to do? Size, what's the size of this resource? Amount, how many of it do you need? Location, where do you need the resource? Time, when do you need it and how long do you need it for? And type, is there a specific model or brand? On the slide here, you can see two very different generators, a small little Honda generator that you can carry when you go camping, and a generator, Generac whole facility generator that would need to be towed by a truck on a trailer. When you just say, I need a generator, if you're not specific, you might end up with the wrong one of these two options, right? So we always want to be specific about what you need. Utilize this CSALT method. It's something that the RHCC will recognize. It's something that our emergency management and public health partners will recognize, and it'll help us all speak the same language when we're handling resource requests. The incident command system is a standardized framework for managing emergencies. This is how your fire and emergency medical services, your emergency management, your police department manages incidents. This is the nationwide standard in the first responder and emergency management community for how incidents are managed. It is a scalable system. There's tons of training that you can take on the incident command system. We're not going to cover it all during this webinar. However, what you should take away from this is that under ICS, we assign an incident commander. That is the person in charge. They have ultimate responsibility for this incident. But as you can see here in this example chart, under that incident commander are additional positions that each manage different sections or different roles, and then below them, staff filling those groups and those sections out to actually complete the actions. We talked previously a little bit about span of control and making sure that we don't get overwhelmed at the leadership level by an incident. Utilizing the incident command system and assigning people to specific roles, whether that's logistics, planning, operations, finance and admin, having somebody designated as your public information officer to speak to the media, your liaison officer to speak to other partner agencies, your safety officer, etc. Assigning these clear roles really helps reduce the chaos. It lets people focus on specific key areas during an emergency. There is training. If you go to the Federal Emergency Management Agency or FEMA independent study website, there are great courses, and your regional healthcare coalitions can provide more information on ICS training, but we did want to mention it here as it would be very useful during an evacuation scenario and other emergencies. To recap, we talked about the long-term care mutual aid plan. That is a valuable statewide plan and an associated MOU that promotes facilities helping facilities. The LTC MAP is an agreement between long-term care facilities so that they can help one another in an emergency. Again, voluntary, incredibly useful. We're very lucky to have it in the Commonwealth. We talked briefly about the Virginia Healthcare Alerting and Status System, or VHHA. That is the statewide web-based system for healthcare emergency coordination. If you don't have an account in the VHHA system, it is easy to sign up. It is 100% free, and it is the system of record for how we coordinate across the Commonwealth of Virginia in the healthcare sector during emergencies. And we talked about the Regional Healthcare Coordination Center roles. These are the 24/7 coordination centers for healthcare sector disaster support. There is one at each of the 4 regional healthcare coalitions. They serve their designated regions, and they also coordinate among each other, again, to really unlock those resources across regional boundaries as well. For additional resources, you can contact your healthcare coalition staff for guidance and recommendations regarding skilled nursing facility evacuation, long-term care emergency planning, the LTC MAP, or any other emergency topic related to the healthcare sector. You can also go on the U.S. Department of Health and Human Services Ask for Tracy website. There is a document on special populations, including long-term care and assisted living, sheltering, and evacuation. This link is also, again, available via your regional healthcare coalition staff. For next steps, first of all, we thank everybody for taking the time to go through this refresher on the LTC MAP and evacuation planning. And if you're interested in more information on the LTC map, please contact your Regional Healthcare Coalition staff, including the Medically Vulnerable Populations Coordinator for your Regional Healthcare Coalition, and they will be happy to assist you. Again, on behalf of the Virginia Healthcare Emergency Management Program, thank you for participating in this training.